you hear me? Okay, I can't tell. Is it on?
Yeah.
Okay. Thank you, Brad. It's really it's really a pleasure to be here tonight. As Brad said, this is sort of a homecoming for me. I worked with Brad's father, Dr. Roy Kuhlman, and Dr. Thoma a long time ago here. And this is sort of where I got my first taste of veterinary medicine. So it really is a pleasure to be able to come back and speak here. I actually lived in the apartment next door for about 6 months before my internship started, so it's sort of like an old home. And I'd like to take a second just to thank all the ER doctors here and all the specialty doctors here, as well as the entire staff. It's really been a pleasure working here. Everybody's been great to work with, and I sort of feel like I have the best of both worlds here in Fort Wayne. I get to not only travel around to the different primary care practices and work with the doctors there one-on-one, but I also get to work with the emergency doctors and specialty practices here at Knives, and so it's just been real rewarding for me. One of the great things that I enjoy about working with Knives is that they have a CT machine. And this is my CT machine in Chicago, the one on the right. And I really miss it a lot. It's one of the few things that I miss about practicing in Chicago, is we're getting to work with my CT machine every day. But I do get to read a lot of the CT studies that are done here at Knives, and so that sort of provides me with my CT fix, so to speak. But CT is just a really great imaging modality. It may be my favorite imaging modality that there is. There's so much that can be done with it other than just imaging nasal cavities or backs. There's so many other things, and that's why I wanted to talk about that with you tonight. And I realized that unless you work here at Knives, you probably don't have a CT machine in your practice. And so it might not be something that is on your radar every day on a day-to-day basis. I'm sure you all have a basic understanding of what CT is, but I think it's important, even though you don't work with it daily, it's important that everybody has a good idea of what CT is, what its advantages are, maybe some of its limitations, and different types of studies that can be done with CT to know whether you have a patient that might perhaps benefit from a CT exam. And so that's the goal of the talk this evening. I'm going to start off by just going over a real brief history of CT and how CT images are acquired. I won't spend too much time on that, I promise. But then we'll get into some of the advantages that CT has over conventional radiographs and other forms of imaging, and then we'll get on to some more specific cases of CT. I'm sure you all know that CT images are acquired using X-rays, just like conventional radiographs. And X-rays have been around for a real long time. They were discovered back in 1895 by Wilhelm Röntgen, who was a German physicist. And this is regarded to be the first medical radiograph ever performed. Back in 1895, this is Wilhelm Röntgen's wife's hand. And she got to be the unfortunate guinea pig, I guess. And I say that because to acquire an image like this back in that time using the technology and equipment that was available then required probably about 1,500 times the radiation dose than we would use for a radiograph today. The exposure times were somewhere in the range of 20 to 30 minutes. And so you can imagine some of the complications that the early pioneers of radiology and their patients developed. Fortunately, we've seen improvements in technology with X-ray tubes and detector plates, and so our radiographs that we get nowadays are much better quality, and we use much less radiation dose. But really, over the next half a century or so, the technology and the principles of imaging with X-rays was unchanged. We're producing X-rays that pass through a portion of the anatomy to a detector plate, and an image is produced based on the attenuation of those X-rays. And that's still the basics of radiographs today. Radiographs today are much better, but there still are inherent limitations in radiographs and that make interpretation of radiographs difficult sometimes. And those main limitations are that there's really poor soft tissue contrast and there's superimposed anatomy on radiographs. So CT came along to try to help remedy some of those limitations, and CT has actually been around longer than you might realize. The first CT machines were in function back in the early 1970s, but these machines were quite impractical. It would take about 5 minutes for a single rotation of the X-ray tube around the patient. Only one slice or one image was acquired per rotation. This is an example of the type of image that was acquired. You can see how pixelated it is. You can sort of tell it's a brain, but beyond that, it's really not that useful. And then over the next 30 or 40 years or so, technology improved drastically, computing power improved drastically, and now what used to take 5 minutes for a rotation of the X-ray tube is done in half a second or less. Whereas we used to acquire one image per 5-minute rotation. CTs are now all multi-detector, multi-slice CTs. Some of the more advanced machines that are being produced these days are acquiring 256 or even up to 320 slices per rotation. So immense amounts of data are being acquired in a very short period of time. In the veterinary field, we're sort of somewhere in between there. There's always that trickle-down technology into the veterinary field, but even now, most CT machines that are being placed into veterinary hospitals, teaching hospitals or private practices, are multi-detector types of helical CT machines. It may not be 320 slices, probably somewhere in the range of 4 to 64 slices, but honestly, for our applications in veterinary medicine, that is typically sufficient. So how does CT work? Well, just real briefly, there's an X-ray tube here, there's a row of detector plates here, and this spins around the patient as that patient travels through the gantry. And this detector plate is constantly measuring the attenuation of those X-ray beams as it circles the patient. The X-ray beams are collimated into very thin slices, somewhere in the range of about 1 to 5 millimeters. So the attenuation of those beams is constantly being measured. That X-ray attenuation information is then converted into digital information, which is then placed into a digital matrix, which is then displayed on a monitor, and we have our CT image. Beyond that, if you need more information, there's plenty of good physics books out there. I have the one on the left there. I'd be happy to loan it out to anybody who is interested. But basically, this is the gist of it. We've got an X-ray tube and the detector plate, and it starts spinning around. And when I saw this video on YouTube, I was kind of blown away. I've never seen the inside workings of a CT machine. It's a lot of hardware spinning around very rapidly, and when you think about how precise that has to be, and all the while it's relaying tons of digital information to a computer to be reconstructed into digital images, all while the scan is being done, it's pretty cool. And I saw it online, and I called my wife over and I said, "You got to take a look at this." And she came over and looked at it for about 2 seconds and called me a big dork and walked away. And I probably am, but that's okay. I still think it's quite a remarkable achievement. So what does this all do for us? What are the advantages of CT? The main advantage is that because we're taking images in a transverse plane, we are eliminating the effects of soft tissue or tissue superimposition. And what that does is it provides excellent spatial and anatomic detail and really improved soft tissue contrast. There still are limitations as far as soft tissue contrast goes. We're dealing with X-rays, and all soft tissues have a very similar X-ray attenuation, whether it's the liver or the spleen or a big tumor. But because we don't have the superimposition, we do get much better soft tissue resolution. The use of contrast, IV contrast, really enhances the ability to evaluate the soft tissue structures. And then the other advantage of CT is because this is all digital information, we're able to take that information and manipulate it in a variety of ways after the scan is done as far as post-processing goes. And I'll go over some examples of that. But this is just an example of the superiority of CT over radiographs as far as soft tissue contrast goes. This dog presented with a cervical swelling on the side of its neck, and a lateral radiograph was taken, and I really can't say that this isn't just a fat dog. There might be some soft tissue swelling here in the submandibular area, but I certainly don't see any kind of a defined mass there. CT was done, and we can see a large soft tissue swelling here on the right side of the neck. The central area of the mass is fluid-filled, so we were able to determine that this is a big cervical abscess, probably due to a migrating oropharyngeal foreign body, as opposed to a tumor like a thyroid tumor. CT is great for soft tissue, but where it really shines is imaging bony structures and air-filled structures like the lungs or the nasal cavities. And these are just a couple examples of that. This is a cat with head trauma. Radiographs were taken and were fairly unremarkable, and a CT exam shows a clear depression fracture here near the base of the skull. As far as imaging air-filled structures, this is a dog that had a nasal carcinoma, and a scan was done of the chest as a metastasis check. And I don't know if you can see in the back of the room, but there's lots of tiny little pinpoint soft tissue nodules in these lungs that only measure about 1 millimeter or 2 in diameter, and that represents metastatic disease. So CT is much more sensitive at detecting early metastasis in the lungs compared to radiographs. If you think back, pulmonary nodules need to be about 5 millimeters in diameter before they'll be able to be detected with radiographs, and that's under pretty good conditions. And I'm not saying that every dog that gets a metastasis check should have a CT exam done instead of radiographs, but I would argue that there are plenty of cases, depending on the type of tumor that the dog has and the treatment plan that the owner is considering, how expensive that treatment plan is, and et cetera, that it might be a good investment to do a CT study of the chest to make sure that there's not early metastatic disease prior to undergoing therapy. I mentioned contrast enhancement briefly and its usefulness in evaluating normal soft tissue structures, but it's also helpful in identifying potential lesions within those soft tissue structures. Lesions such as tumors or other types of lesions may have an increased vascular supply or a decreased vascular supply relative to the tissues surrounding them. And so the use of IV contrast enhancement can help identify those lesions on a CT exam. Other types of contrast studies that are done are CT angiograms, CT myelography, IVPs, and even lymphangiograms. Basically, any type of contrast study that you can do with radiographs, you can do with CT. This is an example of contrast enhancement. It's another cervical mass, and this mass, as opposed to the other one, is very strongly contrast enhancing. This is a thyroid carcinoma, and thyroid tumors are notoriously very vascular, and so they light up with contrast very, very quickly. Might not be something that was necessary in order to make the diagnosis, but one useful thing that this study provides is determining the extent of the tumor. A lot of thyroid tumors are quite invasive into the surrounding soft tissues, as opposed to this tumor here, which has a fairly well-defined capsular margin without any invasion into their surrounding soft tissues. So this tumor was deemed to be surgically resectable. As far as imaging of the brain goes, I'm not going to tell you that MRI is not better than CT, because it is, especially with vascular images or vascular conditions or inflammatory conditions. But there are plenty of conditions that CT is more than adequate for, and especially dealing with brain tumors, whether it's a primary brain tumor or a metastatic disease in the brain. When we see masses in the brain, oftentimes there will be associated hemorrhage or edema, and that can show up even on the non-contrast study here. We see this area of hypoattenuation in the left hemisphere of the brain, and that's due to edema. And then when we give the contrast and do a post-contrast scan, a lot of tumors will cause disruption of the blood-brain barrier, and when that happens, we'll see contrast enhancement, like this rim-enhancing mass that was a glial cell tumor. I'm not sure how many of you do IVPs, looking for ectopic ureters, but if you do, you know how frustrating it can be. It's not hard to get contrast into the ureters. It's just an IV injection of contrast agent. But what's really hard is to get that X-ray, the radiograph, taken at the appropriate angle in order to see where that ureter is terminating into the bladder or the urethra, and it can be extremely challenging. Even with fluoroscopy, it can be difficult sometimes, but with just standard radiographs, sometimes it can be impossible to see where that ureter is terminating. So what I like to do is, if I can't make the diagnosis of an ectopic ureter on ultrasound, I will recommend an IVP done with CT. And this is a volume rendered image of a CT IVP, and we see the kidneys very clearly. Both ureters are well demarcated with contrast, and this was actually a normal study that did not have an ectopic ureter, but you can see both ureters coming down and terminating into the bladder at a normal position. As I mentioned, post-processing is really important in evaluating CT studies. The most common type of post-processing that we do is windowing the images. And if you have digital radiographs in your practice, you're very familiar with what that is. It's the same sort of concept. You get a radiograph and you can adjust that image to view different areas of the radiograph depending on the exposure or what type of, whether it's the lungs or soft tissue or bones. And we can do the exact same thing with our CT images. These are 3 of the exact same images acquired from the same study. They're just windowed a little bit differently. This is a bone window, and we can see the detail of the vertebrae and the ribs here. We switch to a soft tissue window, and we can see much more detail in the musculature of the spine. We can see the heart, and we can even see the contrast pool within the ventricle. We can see the non-enhancing fluid surrounding the heart and the pericardial sac. There's a nice contrast-enhancing mass there within the pericardial sac. And then we can switch to a lung window, and we see much more details in the lungs. We see the pulmonary vessels, and then we see one nodule here and one nodule here that represent metastatic disease in the lungs. So it's always important when you're evaluating a CT study to look at different areas with different windows, even if you're more focusing clinically on one area. Other types of post-processing that are done are image reformatting and 3D reconstruction. And basically what this is we're taking all the individual slices in that image, and that may be 50 slices to several hundred slices depending on the size of the anatomy that you're scanning, the slice thickness that was used. But we're taking all those images and we're basically compressing them together and forming a 3D reconstruction, or compressing it together and imaging that data at different slices. And so this is a dog that had intervertebral disc disease. There's a large mineralized disc up in the vertebral canal. It's not really a hard diagnosis to make, but this is just an example of a sagittally reformatted image. And we can see that disc material right here at T13L1. So these types of procedures oftentimes don't add a lot of diagnostic information necessarily over the original images, but sometimes it can improve spatial recognition of lesions and may improve surgical planning in certain cases. The quality of these exams, these reformatted images, is always dependent on the slice thickness that is acquired, that the original study is acquired at. And because CT machines have gotten much faster nowadays, we typically take larger numbers of slices at thinner slices. And so what we used to do is 5mm slices, and you can see what a 3D reconstruction looks like, how pixelated it is. This is another study that was acquired at 1mm slices, and you can see how much more detail there is. When we're scanning at 1mm slices, we can get what's called isotropic resolution, and that just means we have the same resolution at any plane that we reformat it in as the original transverse images. And this is just another example of that. This is the transverse images that were acquired at 1mm slices, and we can reformat that in sagittal planes or dorsal planes and get the same resolution as on the original images. And this is just another example. This is a dog with an MLO, or multilobular tumor of bone. And this is the primary scan that was done, and we can see a large bony mass here on the skull, which is very typical in appearance of an MLO. And we can see bony invasion into the intracranial cavity. This is the dorsal reformatted image. And then because we took 1mm slices, we're able to get pretty slick 3D reconstruction as well. And you could probably make an argument that this doesn't really add a whole lot of useful clinical information to the surgeon, but I like to do it anyway because it's pretty cool. So now we're just going to move on to different areas of the anatomy and different types of studies that are done in those areas, and we're going to start with the head and kind of work our way down. I've already mentioned, as far as the brain goes, a little bit about MRI being superior to CT in a lot of cases, but CT is very good for brain tumors, and I actually prefer CT over MRI in cases of acute head trauma. I'll go over that in just a few minutes. Nasal cavities, we're all aware of the usefulness of CT for evaluating nasal tumors and fungal disease. Different types of masses, whether it's a retrobulbar mass or a mass like that MLO, CT is great for identifying the extent of tumors, as well as for ear disease, middle ear disease, inner ear disease. And this is a good example of that. This is a 10-year-old dog that had about 8 months of recurrent ear infections, and finally a tumor was identified in the horizontal portion of the ear canal. And so a CT was done to evaluate the tumor extent and determine whether it was something that would be surgically resectable or not. And here on the post-contrast study, we can see a contrast-enhancing mass right at the base of that ear canal. It doesn't extend into the middle ear, so the tympanic bulla was normal. There's no destruction of the petrous temporal bone or the inner ear structures. And there's really not a lot of soft tissue invasion into the tissues surrounding the ear canal. So this was a ceruminous gland carcinoma that was determined to be resectable with a total ear canal ablation. I've already showed you this image here. This cat was found outside with some ocular trauma and had some neurologic symptoms. CT was performed, and we identified this depression fracture. But again, it's very important that you don't just look at the fracture. in a bone window. When we switch to a soft tissue window, what we see here is this large hyperattenuating mass associated with the fracture. And this is a large hematoma formation that occurred within the brain. And this is not a post-contrast study. Acute hemorrhage in the brain will show up as hyperattenuating on CT exams, and that's one of the reasons why I like CT for acute head trauma. The others would be because of its bony detail that it provides looking for skull fractures. But also when you've got a patient with a head trauma, you don't necessarily want to stick them under anesthesia for 30 minutes or so to do an MRI, and so we can put an animal on the table for a CT exam and be done in a matter of a few minutes, sometimes not even needing general anesthesia, just using some sedation. This is a 15-year-old dog with recurrent nasal discharge, and so a CT study was done to evaluate, and an obvious large mass was identified in the right nasal cavity, filling the entire nasal cavity, destroying the cribiform structure, or the turbinate structures. I could pause this, but it's not letting me do that now. But the extent, what's really important is identifying the extent of the tumor. We could get we can do a blind biopsy and make a diagnosis of nasal tumor in this case very easily, but the CT helps us identify that this mass is extending back into the nasopharynx, it's extending back into the retrobulbar space, and even causing some lysis here at the base of the skull, right in this area, in the sphenoid, basisphenoid bone. And you can see that here on this reconstructed image where this bone is destroyed, and now that tumor is in direct contact with the frontal lobe of the brain. As far as CT scanning of the thorax, CT is really the best way at evaluating the lungs. It's great for evaluation of the mediastinum and thoracic masses. We've already talked a little bit about some of the limitations of radiographs. And ultrasound, it can be useful in thoracic imaging. It's great for cardiac imaging. It can be useful for evaluation of mediastinal masses. But ultrasound can be difficult and is limited by the air in the lungs. And so that's where CT is really helpful, because it helps eliminate all those problems. And with helical CT and multi-detector CT, we can scan an entire thorax in a matter of seconds. There's very little motion artifact, and we get nice, thin, very detailed slices. This is a 10-year-old lab that presented with acute panting and lethargy, and there's clearly some effusion in the chest. But other than that, it's a little bit difficult to tell what's going on there. Is this a mass in the chest here, or is this just effusion? The other thing that we can see is there's some osteolysis of this sternum down here, which is kind of an unusual finding. So we did do a CT exam in this case, and there's a large proliferative and osteolytic mass on the sternum here that ended up being an osteosarcoma. When we switched to a lung window, we see a fairly good sized pulmonary nodule here that we couldn't see on radiographs. There's another much smaller nodule here up in the dorsal aspect of the lungs. So this patient unfortunately already had metastatic disease. This case is a dog that presented for ventral swelling and edema of the cervical region, and so an ultrasound exam was performed, and a large mediastinal mass was identified that was most likely either lymphoma or a thymoma. And like I said, ultrasound is really good for evaluation of masses or identification of masses, and it can be very useful for ultrasound-guided sampling of masses. But it's really hard sometimes to identify the extent of the mass in the mediastinum. And so knowing whether a mass is surgically resectable or not, what kind of structures is it involving in the mediastinum, is difficult to tell with ultrasound alone. So if I have a client that is considering surgery to remove a mediastinal mass like a thymoma or a thymic lymphoma or something like that, then I will oftentimes recommend CT to evaluate whether that mass is resectable or not prior to splitting the chest open and getting in there. And that's what we did in this case. This is a sagittally reformatted image of the CT exam, and there's a large soft tissue mass here in the cranial thorax. This is the heart, and we can see the aortic arch with the brachiocephalic trunk and the left subclavian artery coming off, and those arterial structures are being displaced dorsally by the mass, which is good. But unfortunately for this dog, this is the cranial vena cava right here, and it is totally encompassed by that mass and was obliterated by that mass, and that's why the dog had the cervical edema. But unfortunately this dog, or this mass, was not considered to be surgically resectable because of that. CT is a lot more sensitive than radiographs at evaluation of the tracheobronchial lymph nodes. And the reason why this is important is because metastasis to the tracheobronchial lymph nodes is a big prognostic indicator in dogs with primary lung tumors. In a couple studies that were done, dogs that had lymph node metastasis had a median survival times of 60 days and 131 days following surgery. Dogs without lymph node metastasis had a median survival time of greater than a year. So you can see how it might be important to know prior to surgery whether there is lymph node involvement prior to doing that surgery. And this is an example of a dog with a large primary lung carcinoma here in the right caudal lung lobe. When we scroll further to the base of the heart, we can see this large heterogeneously enhancing tracheobronchial lymph node, and that's a very typical pattern of lymph node metastasis. Don't do a lot of CT lymphangiograms, but I put this in here because it's kind of a different type of study, and I kind of think it has some cool clinical implications. When I'm imaging, or when I'm doing CT lymphangiograms, what I'm imaging is the thoracic duct, and that's done in cases of idiopathic chylothorax. And chylothorax can be a kind of a frustrating disease to deal with. It's usually caused by some sort of obstruction of the lymph drainage from the thoracic duct into the venous structures in the cranial thorax. And that may be due to a mass effect, it may be due to heart failure, but in large part in veterinary medicine it ends up getting termed idiopathic, and we don't know what causes the chylothorax to form. So when we don't have a primary cause, how do we fix it? And we do that by blocking the source, and that's done with thoracic duct ligation, which is usually performed here in the caudal-dorsal part of the thorax. I'm not a surgeon, and I've never done this type of procedure, so I don't know how complicated it is or how hard it is to find those ducts, but I think a large part, or a large problem, is the wide variation in the